So, hello, hello everyone. Thank you again for being with us. I'm working today, as all days, but today we have another nice case, and I want to share with you. Before that, I want to invite you to our live endoscopy course, online course that will be on August, last weekend of August. A lot of new things, a lot of new techniques and technologies that you will see, like this one I want to show you today. Very nice cases and nice and incredible faculties that will be sharing with us a lot of their experience in terms of technology, resolution, diagnosis, from the basic to the advanced. So we will have 3 days. So first days will be a half, well, to be honest, 2.5 days. The first day will be Friday, so it's a half day with some lectures from industry, and also some recorded cases that we will discuss with the faculties. And it's nice because it's good to see different things. We will have different topics from the esophagus, stomach, small bowel, colon, and also we will have some biliopancreatic cases that will be presented by different faculties around the world. So thank you to the faculties to be part of this. We will start to share in few days, the final program. I would like to say thank you also to my team and to all my colleagues that has been following us. And we will have also live cases Saturday and Sunday from the IECAD team, and also the faculties from United States and Latam that will be with us this year, and some ones from Europe. So thank you again. It is a pleasure to be with you. So today we have a nice case. This is a 70 years old woman with a cystic lesion and was sent to us because of this reason. So the reason is we need to understand what kind of cystic lesion this patient have. So you have here, so in the image you can see now, this is the B mode in your left and the DFI technology on the right. So I'm using a Fujifilm Itachi Aloka 850 machine with DFI system. So you can see here, so this is very interesting, is with this technology we can replace the contrast just to see the microvascularization. The only thing that is that we cannot see the washout, and the other possibilities that we can have with the contrast. But from the other side is very interesting, because I believe that even in angiogenesis, even in whatever disease, microvascularization and angiogenesis or neurovascularization is very important. So the micro details of the vascularization can help us to have an objective way to measure or to define what kind or the nature of the lesions in general practice. So what I see objectively is that I can see that this is microvascularization in this wall. You can see here, this is the wall of the cystic lesion. This is part of the wall of the cystic lesion also, is this one here. So this one here I cannot see with the microvascularization. This part here I can see with microvascularization, that is this one. You can see here, this is part of the cystic lesion also, and also this part of here. So what I can see is that this lesion by DFI showing me the microvascularization is correct. There is a lot of microvascularization inside this lesion, but we need to start by B mode, right? We need to evaluate the B mode, and I want to come back to the B mode. So we have a pancreatic lesion in the body of the pancreas. You can see here. So this is, I will come back. Excuse me, in the tail of the pancreas. So this is the aorta, okay? So I follow my aorta, and then in the B mode I will find out my celiac trunk. And then once I see the celiac trunk, I can see now my body of the pancreas here. And it's in the body of the pancreas, right? You can see the body of the pancreas here very well. You see in the B mode. So and then when you turn a little bit, you turn, you can see this lesion, cystic lesion, with a lot of microcystic inside and some macrocystic lesion. So this is a mixed lesion, right? So by the B mode and by the characteristic of this lesion, I can say that this lesion, yes, probably is a serous cystoadenoma. But even that, I think it's important to evaluate completely and to have, the tissue, because this is important for the surgeons and even for the patient. So now that I have here this lesion, I can see here, you see the cystic duct, the pancreatic duct, excuse me. If I turn very well, is okay. And then you can see the dilations here, so of the cystic lesion that is in the body of the pancreas, right? So now that I am in the body of the pancreas, what I will do now is to see by E-flow, So the E-flow is the Doppler. You can see, so we cannot see microvascularization. And this is the difference, okay? So not all the technologies are the same. And why to use DFI? So DFI is very important because I can see now the microvascularization right now, right? I want to make the dual, yeah. So you can see a lot of microvascularization in this cystic lesion. So because of the characteristic of the lesion in the B mode, with all these things, and because of the microvascularization here, so I believe this could be a serous cystoadenoma. So now we are evaluating a new technology called artificial intelligence for detection of microvascularization, to count the number. Why to count the number? Because I believe we are subjective. I can say yes, but probably many of you will say no, there is not the microvascularization in that lesion, for example. So I can show it you here. And we come back, you see? You can see a lot of microvascularization in this area here very well. And then you can see here, yes, but I don't know how many microvessels I'm looking during this procedure. So it's very subjective to say yes, you have, or not, you don't have. But you can see very well a lot of microvascularization over the cystic lesion. It's doing like a grapes, you see? The shape is doing like a grape, right? You see here, right? Very good. Okay, so now I will show you the AI. Podemos cambiar la imagen de AI, por favor. So what the AI will do is to count the number of microvascularization per frame per 60 seconds. So I will start the AI, and then we will start to see the number of microvascularization that we can see it. So you see, so the machine count the microvascularization that is looking after the training, and it's make a calculation of the mean vascularity, maximum vascularity, and the current vascularity that is taken. So with that, we can have a mean vascularity of 24 that is high, to be honest, compared with the serous cystoadenoma, which is very interesting. And also when you compare with the neuroendocrine tumors have highest mean vascularity and also highest maximum vascularity. So that proportion is more objective to say when we are seeing a lesion. Okay, so the AI is very interesting and works very well in even in abdominal ultrasound. So I hope to see this technology in the few years, having access to all, of you worldwide. But well, we are still working on this, improving and improving. This is one of the things that I believe is very important. So then, here, very well. Okay, so now I will I will come back to my B mode. We'll stop the AI. And then we will pass to the B mode. Vamos a la imagen normal, por favor. And now I want to take a biopsy from this area. Okay, so this is a cystic lesion. Okay, I want to see the DFI of this area. Okay, and I want to pass a 19 gauge needle because I want to take a biopsy using the Murray biopsy forceps. So it's very controversial in terms of the risk of complications, but the largest series published, yes, there's I think one fatality, I think one patient that have a complication, but I believe it's also the technique, and also where we will take in the biopsy. So now I will take from this area, and then I will change to a 22 gauge needle to take from this area, where I see a lot of just microvascularization, right? Yes. So Juan Manuel is asking me why I will use two needles. Well, I believe there is a component of cystic lesion that is, combined. Sometimes you can have two different lesions, and it appears that it's just one. So I believe it's important to do it, to have tissue and a correct diagnosis for this patient. So I want to share with you this case today. So today, cargada. So yes, my technicians are asking me about, if the needle needs to be alone or with the Murray inside. So this is a very nice question, and I believe it's important that you know that part. That is very important that you preload the Murray because it's easier, it's much better. No necesito aspirar. So, and I will show you a little bit the technique. So thank you to Asteris, also to my good friend Tony Siracusa. Thank you so much for all your help. So you can see here, I will no, aquí está bien. Aquí. Puedes aproximar la cámara. So you can see here, retrocedo un poquito. So she will put just until the tip. Un poquito más. Okay, perfect. So now I am perfect. And then I will pass my needle inside. This is a 19 gauge needle, a standard 19 gauge needle from Microtech. So thank you to Microtech also to be part of the Ecuador Training and Innovation Center. And more big news will be, announced soon. So I'm trying to avoid the vessels. I'm trying to avoid big vessels. I'm trying to go inside the cystic lesion directly because I want to take a biopsy from that area, from that wall. Okay, I am inside, you can see it. And you have to take care, because that could bleed. So now you have a very big image, right? You can see very well. So then what I will do now is to block here, and then I will push my Murray forceps. You see there? Ok, abre. Un momento. Cierra. Un momento. Abre. So you see, now it's open. It's complete open. I will show you here, okay? This is open, this is my needle, and I am inside the cystic lesion. And now I want to see the DFI. Okay, to try to avoid a lot of vessels. So what I can see now is this. So this area have less vascularization and you have tissue in this area. This is my Murray forceps. If I take from this area, for example, you can have more bleeding. So probably, we can use this technology also for, to try to cierra. No, abre. Está abierto. Cierra. Okay, so now I have tissue, you see? So I start to remove. Retira. So you will see despacio. Okay. Okay. Now I have tissue, you see? And oops, no bleeding. So now I take it the whole cystic lesion here inside, the liquid inside, which is difficult. Ah? So we need light because my team is there. Yeah, we have a good one. So I can advance to this one here. Okay, but I will try to pass first my Murray inside to avoid to get out and get inside. Sometimes we need it to do it. Contéstame el teléfono, dile que me llamen en 10 minutos. Okay. Okay. So now I will pass again. So I'm passing the Murray. Here in the body is easier to avoid to pass preloaded, right? In the head of the pancreas sometimes it's difficult. So now I am passing my Murray. But first I want to be clear what area I will take from now. Okay, now I am in other part of the cystic lesion. I will see again with the DFI. I'm okay. And now I will push. No, estamos empujando. Okay. Now we arrive. Now I will remove a little bit. You can see here. So you need to feel it that you have the tissue. Now that I take it 2 biopsies from the big cystic lesions. Now I will take a small biopsy from the using one 22 gauge needle. People say that you can take with 19 gauge, yes, but you know the risk of bleeding is bigger when you go inside this kind of lesion. So I prefer, if I will take front direct for an FNA, is to take in just with one 22 gauge needle to diminish the risk of bleeding and complication. It's not the same. Okay, now so I will finish in a few minutes. Again, thank you for being part of this amazing scientific and GI channel or endoscopy channel. Okay, so now I'm using a FMB needle, poca aspiración. Yes, so I use less aspiration. This is my technique. I know that a lot of people prefer other techniques. It's okay. Each one which his own technique. Okay. The most important is that you need to be effective, and that is all. It's not about what technique is better. What technique is better for you. Okay, now I pass. So I will take just from this microcystic lesion, you see? Very good. No bleeding. I am using a FMB needle. Some people could say too much for this, right? The problem is that US is not cheaper, and we need to have a very good conclusion of this lesion. So for the patient to pay another US will be not, nice if you don't have a good result. We have different techniques like rows and all these things, but we have a very good accuracy when we combine techniques. And that was published many years ago in World Journal of World Journal of Gastrointestinal Endoscopy, I believe. So you can see I try to pass through the whole lesion to have epithelium. Okay, so now, and why I go to the microcystic area? Because less risk of bleeding. If there is bleeding, will be contained inside the cystic lesion. Okay, now I have everything. So well, I will show you in a few minutes just the tissue, and I will now to see if there is any bleeding inside. This is very important. When you finish and you are using needles in this kind of lesions, it's very important to evaluate. So this area is the macrocystic lesion that the end, deconflate after I take the biopsy. This is the area that I take biopsies also. I don't see anything, with the Murray. I don't see bleeding. You can see very well. And then this is the small area that I take it with a 22 gauge needle from the microcystic lesion. So for me, it's a serous cystoadenoma. Let's see what histology and pathology says to us. Let's see. Yeah, there is a very good tissue. No sé si se puede enfocar mejor. So very good core. This is what we have. Very good core here. And I want to see the small biopsies, but that will be more difficult. Let me see. La de la Murray. Ya terminamos. It's really small. It's just two small biopsies there, very teeny. So we finish, and this is very important. Evaluate at the end. Okay, thank you so much again for your time, and stay tuned because very nice course is coming. So see you soon. Bye.